Good day, distinguished colleagues and dedicated emergency medicine professionals. Today, we embark on a crucial exploration of hypertension, a pervasive and often silent adversary that we encounter frequently in the emergency department, ED. Imagine hypertension as a stealthy storm brewing beneath the calm surface, rarely noticed until its formidable power unleashes a tempest of complications. Our mission today is to become adept navigators of this storm, mastering the art of its diagnosis and the science of its management to ensure optimal patient outcomes. Understanding hypertension. Picture the bustling environment of the ED, a place where time is of the essence, and the ability to swiftly and accurately assess a patient's condition can make all the difference. Among the myriad of conditions we manage, hypertension stands out not because of its immediate visibility, but due to its insidious nature and the significant risks it poses if left unaddressed. Epidemiology and significance, prevalence. Hypertension affects approximately 1.13 billion people globally, making it one of the leading risk factors for mortality and morbidity. Age groups. While it can affect individuals of any age, its prevalence increases with age, particularly in middle-aged and older adults. Geographical distribution. High-income countries report higher prevalence, but low- and middle-income countries are experiencing a rapid rise due to lifestyle changes. Risk factors: obesity, sedentary lifestyle, high-sodium diet, excessive alcohol consumption, smoking, genetic predisposition, and chronic stress. Classification of hypertension: decoding the levels. Understanding the classification of hypertension is akin to having a detailed map before embarking on a journey. The Joint National Committee 7, JNC 7, provides a foundational framework that guides our diagnostic and therapeutic decisions. JNC 7 classification: class, normal if systolic less than 120 and diastolic less than 80. Elevated blood pressure if systolic between 120 to 129, diastolic less than 80. Stage 1 hypertension if systolic between 130 to 139, or diastolic between 80 to 89. Stage 2 hypertension if systolic more or equal to 140, or diastolic more or equal to 90. However, as medicine evolves, so do our guidelines. The JNC 8 introduces nuanced adjustments. JNC 8 changes. Patients more or equal to 60 years. Threshold increased from less than 140/90 to less than 150/90. Patients with diabetes mellitus. Any age maintained threshold at more than 140/90. Categorization of hypertension. Asymptomatic hypertension. Definition: systolic BP 140 to 179 or diastolic BP 90 to 109 without symptoms. Hypertensive urgency. Definition: systolic BP more than or equal to 180 or diastolic BP more than or equal to 110. Without end organ damage. Note: many emergency physicians prefer categorizing only hypertensive emergency or asymptomatic hypertension. Hypertensive emergency. Definition: systolic BP more than or equal to 180 or diastolic BP more than or equal to 110 with evidence of end organ dysfunction. Clinical features. The silent indicators. Hypertension is often the quintessential silent killer. Most patients remain unaware of their elevated blood pressure until it orchestrates significant damage to vital organs. Common clinical features. Asymptomatic nature. Patients may present without any symptoms, underscoring the importance of regular blood pressure monitoring. End organ damage may manifest as cardiovascular, chest pain, shortness of breath. Neurological, altered mental status. Focal neurological deficits, stroke. Renal, signs of acute kidney failure. Ocular, blurred vision. Nonspecific symptoms do not indicate end organ dysfunction. Headache, epistaxis, nosebleed. Dizziness. These symptoms, while concerning, do not necessitate immediate blood pressure reduction unless accompanied by signs of end organ damage. Diagnostic pathways. Charting the course. Effective management begins with accurate diagnosis. Let us navigate the essential steps to confirm hypertension and rule out other conditions. Establishing the diagnosis of hypertension. JNC 7 recommendations, criteria. 2 or more properly measured, seated BP readings on each of 2 or more office visits. Measurement technique: ensure accuracy with proper cuff size, patient positioning, and consistent measurement conditions. Evaluation based on hypertension category: asymptomatic hypertension. Routine screening: not mandatory for acute target organ injury, level C evidence. Special populations: consider screening creatinine in select groups to identify potential renal injury. Hypertensive emergency: immediate action required, focus on reducing BP to prevent or limit end organ damage. Suggested algorithm: systolic BP less than 120 and diastolic BP less than 80, action. No immediate screening, manage as normal BP with lifestyle modifications. Systolic BP more than 210 or diastolic BP more than 120 to 130, Chem 7, comprehensive metabolic panel assess renal function. Outcome: if no acute renal failure, manage as outpatient. No additional diagnostic screening needed. Hypertensive emergency: immediate blood pressure reduction. Follow protocols for hypertensive emergencies. Clinical assessment: deciphering the signals. Clinical features to note: most hypertension is asymptomatic, reinforcing the importance of regular BP checks. End organ damage indicators: chest pain, shortness of breath, altered mental status. Focal neurological deficits: blurred vision, signs of acute kidney failure, nonspecific symptoms. Headache, epistaxis, dizziness do not indicate end organ dysfunction. Evaluation, strategic assessment. Asymptomatic hypertension, routine screening, not required for acute target organ injury. Select populations, consider screening creatinine to identify renal injury. Hypertensive emergency, immediate evaluation, focus on diagnosing and managing end organ damage. Suggested diagnostic algorithm: BP less than 120 diastolic, action. No screening ED workup, manage as outpatient. BP more than 210 systolic or more than 120 to 130 diastolic, Chem 7, comprehensive metabolic panel assess renal function. Outcome: if no acute renal failure, manage as outpatient. No additional diagnostic screening tests required. Therapeutic strategies: steering the therapeutic vessel. With diagnosis in hand, the journey shifts towards effective management, tailored to the hypertension category and individual patient needs. Management overview: asymptomatic hypertension, routine ED medical intervention, generally not required, level C. Outpatient therapy. Consider initiating or increasing therapy for long-term control in select populations, level C. Hypertensive urgency, management focus, initiate or adjust. Outpatient therapy without the need for immediate BP reduction. Hypertensive emergency, immediate blood pressure reduction, follow established protocols to mitigate end organ damage. Initial outpatient hypertension medications. For individuals without comorbidities, hydrochlorothiazide dose, 12.5 mg, maximum 25 mg daily. Notes: requires laboratory monitoring before initiation, ineffective in chronic kidney disease CKD. For individuals with diabetes mellitus, DM, and or proteinuria, ACE inhibitors, ACEI, or angiotensin II receptor blockers. ARB example, lisinopril. Dose: start with 10 mg once daily, QD, adjust as needed. Notes: requires Chem 10 before and after starting to monitor for hyperkalemia and creatinine levels. For patients with coronary artery disease (CAD) or congestive heart failure (CHF), beta blockers, example, metoprolol, propranolol. Notes: do not require laboratory monitoring. Essential for heart rate and myocardial protection. For anyone needing additional BP control, amlodipine, dose, start with 5 mg QD. Notes: avoid in individuals with lower extremity edema, does not require lab monitoring. Alternative calcium channel blockers CCB, diltiazem, use, for proteinuria in those unable to tolerate ACEI, no lab monitoring required. For CHF and or lower extremity edema secondary to proteinuria, furosemide, Lasix, dose, based on clinical assessment, Notes: Diuretic therapy to manage volume overload. JNC8 recommendations, tailored approaches. General population, non-black patients, thiazide, CCB, ACEI, or ARB. Black patients, thiazide or CCB. Chronic kidney disease, CKD. Non-black patients, ACEI or ARB. Black patients, ACEI or ARB. Diabetes mellitus, non-black patients, thiazide, CCB, ACEI, or ARB. Black patients, thiazide or CCB. Hypertensive emergency, the critical juncture, in the ED. Hypertensive emergencies represent a time-sensitive scenario where swift and decisive action can prevent irreversible damage. Immediate blood pressure reduction, goal, lower BP promptly but safely to prevent further and organ damage. Approach, utilize intravenous antihypertensives under close monitoring. Common for antihypertensives, nitroglycerin, effective for chest pain associated with myocardial ischemia. Sodium nitroprusside, powerful vasodilator, used for rapid BP control. Labetalol, combined alpha and beta blocker, useful for a variety of hypertensive emergencies. Esmolol, short-acting beta blocker for specific indications. Disposition, hypertensive emergency. Admit to hospital for intensive management. Otherwise, discharge home with a follow-up appointment with the primary care physician, level C. Management, navigating therapeutic waters. Asymptomatic hypertension, routine ED medical intervention, not required, level C. Outpatient therapy, consider initiating or increasing long-term control in select populations, level C. Initial outpatient medications, hydrochlorothiazide, 12.5 mg daily, max 25 mg. ACEI, e.g. lisinopril start 10 mg QD, monitor Chem10 for hyperkalemia and creatinine. Beta blockers, e.g. metoprolol essential for CD and CHF, no lab monitoring required. Amlodipine, start 5 mg QD, avoid in lower extremity edema. Diltiazem, for proteinuria in ACI intolerant patients, no lab monitoring. Furosemide, Lasix for CHF and edema secondary to proteinuria. Hypertensive emergency, immediate BP reduction, utilize intravenous antihypertensives. Admission, for intensive management and monitoring. Hypertensive urgency, manage outpatient, initiate or adjust long-term therapy without immediate BP reduction. Monitoring and follow-up, ensuring safe passage. Key monitoring parameters, clinical response. Expect improvement within 48 to 72 hours. Adverse effects, watch for allergic reactions, gastrointestinal disturbances, and signs of antibiotic resistance. Laboratory monitoring, especially with medications like ACEI, monitor Chem10, and beta blockers, monitor heart rate and ECG if needed. Recurrent infections, investigate underlying causes such as carrier state or immune deficiencies. Complications, the storm's aftermath. Cardiovascular events, myocardial infarction, stroke, renal failure, acute or chronic kidney disease, ocular damage, hypertensive retinopathy leading to vision loss, aortic aneurysm, risk of rupture due to vessel wall weakening, left ventricular hypertrophy, resulting in heart failure over time. Prevention, building resilient shields. Preventing hypertension and its complications is akin to fortifying our defenses against inevitable storms. Preventive measures, lifestyle modifications, encourage a balanced diet low in sodium, regular physical activity, weight management, and smoking cessation, regular monitoring, advocate for routine BP checks, especially in high-risk populations. Patient education, inform about the importance of medication adherence and recognizing symptoms of hypertensive crises. Public health initiatives, promote policies that reduce salt intake in populations and increase access to healthcare services. Illustrative case study, bringing theory to life, patient profile, age 55-year-old female, presentation, presents to the ED with severe headache, blurred vision, and chest pain. BP measured at 185/115 mmHg. History, known hypertensive, non-compliant with medications, history of diabetes mellitus. Clinical examination. Signs of hypertensive retinopathy. Chest pain indicative of possible myocardial ischemia. Clinical approach. Immediate assessment. Recognize signs of hypertensive emergency due to evidence of end organ damage. Retinopathy. Possible myocardial ischemia. Diagnostic tests. Electrocardiogram. ECG to assess for myocardial infarction. Ophthalmologic examination. Confirm hypertensive retinopathy. Laboratory tests. CBC, Chem7, cardiac enzymes. Treatment plan. Intravenous antihypertensives. Initiate 4-nitroglycerin for chest pain and nitroprusside for BP control. Admission to intensive care unit, ICU for close monitoring and titration of medications. Address underlying causes. Assess for secondary causes of recurrent or resistant hypertension. Outcome, BP reduction. Gradual lowering of BP to safer levels under supervision. Resolution of symptoms, headache and chest pain. Alleviate with controlled BP. Follow-up. Discharge with a comprehensive outpatient management plan to prevent recurrence. Discussion. This case underscores the critical importance of recognizing hypertensive emergencies and acting swiftly to prevent irreversible organ damage. The integration of clinical findings with prompt diagnostic testing and targeted therapy ensures optimal patient outcomes. Concluding reflections. Mastering the silent storm. As we conclude our exploration of hypertension in the emergency setting, it's evident that this silent storm demands our vigilant attention and strategic intervention. From understanding its classifications and clinical features to implementing precise diagnostic and therapeutic protocols, our role as emergency physicians is both pivotal and impactful. Empowerment through knowledge, regular screening, advocate for routine BP measurements in all patients, personalized treatment, tailor therapeutic strategies based on individual patient profiles and comorbidities. Continuous education, stay abreast of evolving guidelines and emerging evidence to refine management approaches. Call to action. Let us embrace the challenge of hypertension with informed diligence, ensuring that our patients navigate their health journeys with resilience and confidence. By mastering the art and science of hypertension management, we contribute significantly to enhancing patient lives and fostering a healthier community. Thank you for your attention and dedication. If you found this lecture insightful and enriching, please consider giving it a thumbs up and subscribing to our channel for more in-depth explorations into the ever-evolving field of emergency medicine and beyond. Your engagement fuels our commitment to excellence in patient care and medical expertise. Together, let's continue our journey toward mastery and compassionate practice. Until next time, stay curious, stay informed, and stay committed to excellence in emergency medicine.